All right, so we're just going to give you an overview of the ACLS cases or the ACLS algorithms. We're going to kind of walk through basically just the algorithm part of it, the treatments, stuff that we've already been doing. So this should be looking pretty familiar to all of you at this point, but it's just one more review of it, and you can look at this anytime you need to once we have this online. So with these cases or megacodes or algorithms, however you want to look at them, these are the ACLS, and your protocol guidelines are going to follow ACLS guidelines, but the Dr. Shireen and his protocols may have small changes once they're in them, but they're basically based on the newest AHA guidelines, which are the 215 guidelines, and everything will change again in 2020. So these are just simulated. They're designed to review all your knowledge and skills that you need to take the ACLS course and the megacode skill test at the end of it. That's your major testing device when we give you ACLS in the fall. So you'll go over this, and you'll have the ACLS class. You'll go over this all again, but now you'll also have this from us that you'll be able to start using this more in your cardiovascular centers when you're still doing your clinicals at the end of this semester. We still got about four weeks left. And then when you get on the squad in the fall, all your squad time, hopefully this will look even more familiar to you, and you'll get your ACLS card in the fall. So each case contains the following topics. So there's kind of just a small introduction. There's some learning objectives. But basically, we're going to really look at the rhythms and the medications and treatments that go with them. Overview of all the main algorithms, description and definitions of some of the concepts. We're going to look at the figures, actually the algorithm figures for 2015 from ACLS. So you'll see them again in the fall. And then the use of them, how you work them in a case, and a few other related topics. First, we're going to talk about ventricular fibrillation, VF, treated with CPR and AED. This basically is just an AED CPR testing station. You guys have had this already as BLS certificate holders. You've had this in all of your training as EMTs and your CPR cards. The ACLS interventions, including advanced airway control, IV medications, are not really in this part of the scenario. We're just starting out with basic CPR and AED. You'll be able to, and you'll have to show us those in the class, so the ACLS class, you will do this part of it also. You'll just do the CPR up to AED initially, just to show that you're competent in basic skill performance. Demonstrate skills and sequence outline the BLS algorithm, high quality CPR and use of the AED. We'll implement the healthcare provided algorithm by perform one-man CPR, implement BLS healthcare provider algorithm by operating the AED. All right. Pitfalls to this thing is there really isn't any rhythms to learn in the case. The AED will analyze and shock any shockable rhythm, like you already know. There will be no drug use. So this is all just basic CPR skills in AED, like any lay person can be taught how to do. The ventricular fibrillation is treated with CPR and AED. It requires only that you demonstrate competency in the basic skills. So that's all you need to show us in the station when we do ACLS. All right. You will be able to do all of that. You already know how to do that, so this should be, that part will be cake. Now we'll start moving into the pulseless VFib and VTach cases. So these will focus on the assessment and actions used for a witness cardiac arrest due to VFib or pulseless VTach that's refractory to the first shock. So refractory to the first shock means that it goes right back into it. The first shock doesn't knock it out. We want to shock these rhythms as quickly as possible because they are shockable rhythms. And our goal is to shock them out of this rhythm into something else. Manual defibrillation is required in the case, so we have to show you how to actually use the paddles if you ever had to use them, but you'll still have to do that for us, just to show that you can, all right? And you'll do that the rest of the semester. We'll go over that manual defibrillation with paddles. You'll have to recognize the rhythm so you can treat it correctly, use the drugs that go along with that case and the sequences, IV-IO access, and advanced airways. So you'll basically run a megacode like a sort of a simulation for us in ACLS in the fall, which is a little different than what most ACLS classes are, but we're going to give you a little bit more of that so you actually get the more of a feel of that when we test you out. So we need to recognize VFib and pulseless VTach on the monitor, manage a scenario. That doesn't just mean the algorithm, that means all the team members, okay? Demonstrate knowledge of recommended drugs, including the indications and what counterindications are and what the doses, as well as your routes of administration. So you're going to need to know your cardiac drugs. So the cardiac drugs that you're going to know here are ones you're going to use a lot, so you need to know those. You need to demonstrate the appropriate defibrillation skills. If return of spontaneous circulation occurs, then we need to support blood pressure with fluids and or pressors. All right. Ensure we have adequate ventilation and the use of capnography. Waveform capnography is preferred, but we'll take numbers if we can get them continuously. Is it a STEMI protocol? Make sure we look at that with our 12 lead, because we want to do 12 lead on these people right after something comes out of it. We want to check what's going on. We want to assess a level of consciousness and consider if we want to start putting these patients into a therapeutic hypothermia, which in our case is probably just going to be use of cold pads maybe to the throat, neck area, and the armpits and groin areas to help start a cooling process down, and the hospital will take care of the rest of that. Most of that's for the preservation of neural function more than anything else. They are finding some benefit to doing that also for some of the cardiac status. And then we want to get our patient, treat all reversible causes, and get our patient into the appropriate system of care at that point. So a participant must be able to recognize VFib, pulseless VTAC, EC artifact that might look like VFib, or a new left bundle branch block that may occur that make it looks like wide, which makes it look more like VTAC, but it really possibly just isn't originating from a higher pacemaker site higher in the conduction system, supraventricular is what I'm trying to tell you. The drugs we would use for VFib and VTAC pulseless, all right, would be epinephrine. We may use norepinephrine. Vasopressin still listed here. We probably don't use that anymore at all. So amiodarone, lidocaine, mag sulfate, dopamine, oxygen, and another one that they have it listed here is procainamide. So procainamide is going to be, and we'll see that on the algorithm, that's going to maybe come into play before we get to anything. So the epinephrine, the amiodarone, oxygen, mag sulfate may use in refractory or torsade situations, and then the procainamide or lidocaine will be your antiarrhythmics of choice in certain situations. You don't really use the vasopressin's pretty much not used anymore, and norepinephrine, we may start a norepinephrine drip. That may come up, but that would be down the line, and that would be something we would use probably more in a critical care setting than we're going to use pre-hospital. So here's your cardiac arrest algorithm. Here's 2015. Here's the newest update. So this is what you'd be looking at. So of course we're going to start, right off the bat with CPR, oxygen, a Tach monitor, defibrillator. We want to shock it as quickly as possible. So if we have a shockable rhythm, which is yes, would be VFib and VTAC is what we're talking about. We go down this tree right here. So we deliver our shock at 200 biphasic or 360 or the equivalent of. Shockable rhythm, we shock, IO access, we can have someone else doing that while you're running the syndrome. All right, we continue with the shockable rhythm. So if he stays in the shockable rhythm, refractory, like we were talking about, refractory to the first shock, CPR for 2 minutes, establish IO access, so we can start giving medication. So we give him another shock. Yes, we give him another shock, continue down here to remain in the same rhythm. CPR, then we can maybe give at this point, we can start giving some medication since we have access. IO and epinephrine 1 milligram every 3 to 5 minutes. You can see our drug therapies over on this side, on the right-hand side. So you have your epinephrine every 1 milligram every 3 to 5 minutes. Continue till that CPR is over with. The CPR is circulating our drug for us to help make something happen. We shock them at that point. At that point, we continue in that. We want to go right down and continue with our CPR. And now we start thinking about amiodarone. So we want to give them a dysrhythmic, antiarrhythmic to get them out of that rhythm. So the idea is to shock them out of VFib or VTAC. And hopefully it'll pick up in a higher pacemaker site, or at least go into systole where we're not dealing with the VFib or VTAC again, which is going to be pulseless for us. We can go over here to our amiodarone. Our initial dose is 300 bolus, and then we end up going down this and continuing down shock, CPR, shock, drug, CPR, shock, drug, CPR, shock, drug. And in between these, we'll be alternating our epinephrine every 3 to 5 minutes. So he'll be keeping track of that. And you'll have someone keeping track of that. So as a team leader in your mega code, you'll be pretty much just directing everyone and what we want them to do and listening for anyone's input. If at any time the shockable rhythm shocks into something that is not shockable, then we go down to this tree. If no signs of return of spontaneous circulation or ROSC, then we go right back up to 10 or 11, because these are now rhythms that have no pulse, but they're not shockable. And we'll talk about that in a second. If you look on the right side, it tells you how to go through your CPR, what you're looking for, all right, your ratio, what your end tidal CO2 should be looking like. Hopefully it will if it gets below 10 on your end tidal, then you need to have someone pushing faster and harder. That's stuff for you to think about. Your inner arterial pressures, relaxing phase, 20 millimeters. If you start seeing 20 and in the 20 areas, so attempt to improve CPR quality for that also if you have inner arterial pressures. But you won't have that in a pre-hospital setting. This gives you your shock and defibrillation modes. Monophasic, you 360, and the equivalent of 360 is 120 to 200. If you don't know, you hit them at 200, what your machine's capable of, if that's the case. Your drug therapy is listed here. Pretty much, this is the only 2 drugs you're going to be dealing with a pulseless situation at this point in the game, probably as long as you'll have someone. If you have return of spontaneous circulation, it shows you what to monitor. You put an advanced airway in, we know we want to monitor and give a breath every 6 seconds at that point, in between compressions. And down here we start thinking about reversible causes. Once we've gotten through a 1 round and all the way through to a round of an antiarrhythmic, okay, what can we change here? So we can change hypovolemia, the H's and T's, as we say. So those are things that we may want to change. Now, if we get in the case where we do have someone that's pulseless, we have pulseless electrical activity case or pulseless PEA or asystole. You treat them both basically the same. You must demonstrate high quality CPR and great ventilations, recognize the rhythm, and implement the appropriate care. So look at the signs and symptoms of PEA. So we may have a nice looking rhythm, but if it's not perfusing, it's not doing us any good. We have to acknowledge the correct use of epinephrine in PEA and the dosage. Want to use basically the vasopressin in PEA is not present anymore, so please disregard that. I'm sorry I didn't update that slide quickly enough. So you're basically in PEA and systole, you're doing high quality CPR, assigning team functions, and giving epinephrine until something changes. Any rhythm other than pulses, VTach and VFib or asystole that do not have a pulse. So you have a rhythm, but we don't have a pulse is PEA. Which basically you have to figure out what the underlying rhythm that it's showing you. You still need to identify that, if it's fast or slow. If the QRS complexes are wide versus narrow, because that also may change things to a VTach if it's too wide. The drugs we're going to use in PEA is epinephrine. There may be some other meds. It depends if there's some other H's or T's that we find, like for toxins and so forth, that we need to reverse. Once again, vasopressin is not in this algorithm anymore, and I'll try to eliminate that for you. And just remember, it's just epi, everyone. Make it easy. PEA. Perform epi all times. Okay? So here is your updated algorithm. It's just the same algorithm that we showed you earlier. These are all the pulseless cardiac arrest algorithms. So you start all of those the same. Is it a shockable rhythm? And in this case, it would be a non-pulse producing rhythm or asystole. We all know asystole is just flatline. We know what that is. So there is no shockable rhythm. We continue with CPR, IV access, epinephrine every 3 to 5. Consider advanced airway so we can monitor capnography and ventilate them more appropriately, like we show here on the right. Shockable rhythm, no. Continue CPR. And now we start looking at reversible causes, because now we need to start looking at why this is happening. We continue the CPR, IV epinephrine, CPR, IV epinephrine, and start thinking about causes and start treating reversible causes. If we go into ROS, then we go into post-cardiac care, and if we continue to stay where we're at, we start thinking about just continuing this down the line, or we might start thinking about giving some things like possibly some bicarb down the line because of his acidosis and some other treatable causes, and if we don't find any other treatable causes. So managing PEA and asystole basically is diagnosing and treating the underlying causes. PEA has usually very poor outcomes. Rapid assessment and aggressive management offer the best chance, so you search for the determination of what caused that PEA. For example, I've told you about the traumatic PEA I had on a 42-year-old school teacher, where basically she was in hypovolemia because of trauma. Once we filled her with fluid, she had a sinus tachycardia with no pulse and no blood pressure. Once we gave her a bolus of fluid, she had a blood pressure again of in the low 60s. And we recognized also that she did have also another cause of a pneumothorax, tension pneumothorax, a tension pneumothorax. We relieved the tension pneumothorax, and she had 120s on her PEA. It now turned into a sinus Tach with a BP of 120 over 80 within a minute or two after decompressing her chest. So that's what we're talking about as far as searching and determining what the causes of that PEA and aggressively manage them as soon as possible. The common causes of PEA, here they are: hypovolemia, hypoxia, hydrogen ion excess, or acidosis. That's what causes our pH to become acidotic and move to the left side of the pH line. We could have hyper or hypokalemia and hypothermia. And what can we do in the pre-hospital setting for all of these? We can treat every one of these. We can do something about every one of these H's in the pre-hospital setting. If we look at the T's on the right, tension pneumothorax, we can fix that. Tamponade, cardiac tamponade, can we fix that? We can't fix that, but we can recognize it and get someone who can give pericardial centesis and relieve it. Toxins, we can assess the scene and so forth once we protected ourselves at that scene for any type of toxic overdose. So even toxins we talked about yesterday and the other day about, it could be therapeutic medication. Hey, I took an overdose of my beta blockers. Next thing you know, I don't have anything going on here. Pulmonary thrombosis or coronary thrombosis. So we throw a clot either to pulmonary circulation, like a PE, which blocks now that's a physical blockage that we can't have exchange of gases in our system. So we can't do much about that. But you have SATs that are down in the as far down that just drop suddenly. We can suspect that with a patient's history. And also coronary thrombosis from their history also, and maybe prior history too, if we have access to prior histories of both of those. May close in that that's what we're dealing with, and that's once again something we need to recognize and get to some place where you can do some more definitive care with that in the hospital setting. So here's some clues and some of the conditions that go with some of the H's here. All right, so hypovolemia, clues from your ECG, a lot of times it's neurocomplex rapid because we're trying to compensate. History of flat neck veins. Potential effective interventions, and we give them some infusion. So there you go. Hypoxia, it may have a slower rate. We start to become more bradycardic for some reason, well, because of the lack of oxygen, of course. Look, physical exam and history, what we get, we see cyanosis. If we got access to blood gases, they are all whacked off. Our end tidal for us will show high end tidal because they're retaining. We're retaining the low sats, and we're retaining carbon dioxide levels are going to go up. So what can we do? We can improve the oxygenation. That's how we get the oxygen levels back up, and then we adequately ventilate, maybe use of an advanced airway to protect their airway and maintain it so we can maintain it ourselves if they can't maintain their own. In these cases of pulseless people, they're not going to have access. We're going to need to provide that for them, their airway and ventilations. Acidosis may show a small amplitude QRS, so your QRS is going to be smaller, shorter. You can maybe try to turn that up, but recognize that maybe we've already got some acidosis occurring. If we got history of diabetes, if we get a bicarbonate level, we're not going to have that in the field, but you may eventually someday in your practice see that with some of the iStats that you're going to have available to you in the field, perhaps, depends where you work. Ventilation is the best thing we can do for acidosis right away. So by blowing off the CO2 levels and keeping them in the 35 to 45 range, that will coincide and help correct and keep pH hopefully between 7.35 and 4.5. If we do know a bicarb level, or if we're down at the end of the algorithm and it's been up to 10 minutes or so, we start thinking we have metabolic acidosis occurring. Also, we might think about giving them some bicarb. So we consider that at the end of some of those algorithms when we're not getting anywhere with the pulseless algorithm. Hyperkalemia, so high potassium, we're going to see tall peak T waves, right? The P waves will get smaller, but the T waves will be peaked and higher. And you might see a little widening in the QRS, more than what's normal, a wider QRS. But the peak T waves are what really help. Yeah, so remember, high and a peak T wave, so you have a high T wave. You have a history of renal failure, diabetes, dialysis, home dialysis, recent dialysis. You see a fistula on somebody, you see a tag on them. Those are all clues that those things can really mess up your potassium levels, those kind of histories. And that makes you more specific, and you tag those two together along with peak T waves, and you start suspecting that hyperkalemia is your problem. So we can treat them with hyperkalemia. We treat them with what? Calcium chloride or calcium gluconate. We could give them bicarb if we know they've become a little acidotic with it. In the hospital, we may give them, they need glucose because of the diabetes. We'll give them insulin, and then we'll probably also have to really keep a close eye, because once you start dumping insulin on somebody and bringing in glucose, you're also might make them hypokalemic at the same time. You can give them possibly a continuous albuterol treatment, which also removes potassium from the blood, which will reduce the hyperkalemia and the high potassium levels. So you may have some of that in some of your protocols. We can do that for hyperkalemia also. So we give them calcium chloride, and we can try continuous albuterol treatment through the tubes. Hypokalemia, we have T waves are flattened. Wide QRS, we have the QT interval is starting to length out. And you might see some more wider complex tachycardias. You may have a more prominent U wave following S wave, but if you're not used to seeing those, it's probably something you might not notice. So you can become more familiar with them if you'd like to. So probably one of the biggest reasons we see somebody that's on diuretics at home, and with the use of loop diuretics, the problem with loop diuretics and the use of them that's not, or the overuse of those, if they're not having potassium supplementation, is that we might lose potassium also through that mechanism. So what we could do is add magnesium if it's in a cardiac arrest we suspect hypokalemia. So that's where you might use mag sulfate. If it's refractory VTAC, doesn't come out of it, we're getting down the road, it's like you're not seeing too much of anything else going on, and you may decide that you might want to, that might be an option for you to give magnesium. Hypothermia, you might see a small J or Osborne wave right before your P wave. And you have, of course, your history of exposure to cold and temperature drop. You can have somebody in the lake. Right now the lake's 72 degrees. You got somebody that's been in the lake for too long and goes into a rest. I'm pretty much going to tell you that that's still a cold water drowning, even though people are swimming in it in the middle of summer. So consider that exposure part and how much they've lost, and get your core temperatures. Then you just go to the hypothermic algorithm, slowly warm them and treat them. And you got to treat them a little more gingerly as far as CPR and moving them around too much. For your T's, we have tension pneumothorax. You might see more of a narrow complex tachycardia because then we're trying to compensate. So we're going to look at our history. No pulse with CPR, Neck vein distension, just like we talked about. What's going to show us tension pneumothorax? Jugular vein distension, tracheal deviation late, unequal breath sounds when you ventilate, difficulty ventilating because we have only one lung to ventilate. So what we want to do is we think we're going to have that from whatever mechanism and history or where you pick them up at. And what we can do is decompress their chest. So as medics, we can decompress their chest. As advanced providers, they'll put in chest tubes also. But the needle decompression will get us by, and we can do it several, 2 to 3 different times if we need to en route. Tamponade, again, a narrow complex rapid rate EKG monitoring of some type, still supraventricular hopefully. There's no pulse with CPR, there's JVD, but we have breath sounds, so that's going to differentiate that from your tension pneumothorax. The treatment for that, of course, is pericardiocentesis. I know I showed you in class how to do that, but that's not in our scope of practice. But we need to recognize that's what we're dealing with, and then we need to have rapid transport and continue our CPR as effectively as possible. When we start talking about toxins, we're talking about that in medical emergencies right now, so that would be our T's. We're talking like tricyclics, DIG overdoses, beta blockers, calcium channel blockers, anything that will cause us to have no pulse or slow pulse or PEA. So they can have various effects on the EKG, depends on the mechanism, depends on the drug and its mechanism of actions. Definitely usually see a predominantly prolonged QT interval. That's something to tell you that you're on some of these different toxins that it might be overdosed on their own medications. Bradycardia, empty bottles at the scene, check their pupils for dilation or neurological exams not coming out. We want to intubate these guys, and once we find out, like, hey, I got a bottle of cardizem laying there, calcium channel blocker, and it's empty, and it was just filled 2 days ago. Those are all clues that that's something going on there, and what can we do? But we just treat that toxic agent. So whatever it is, if it's beta blockers, you give them glucagon. Calcium channel blocker, you give them calcium. And tricyclics, you just follow your protocols for whatever agent we think is the toxin, as much as possible. All right, so for clots that we've thrown PEs or heart, MIs or showing a large coronary occlusions, you're going to see the thrombosis, narrow complex rapid rate with the PEs, because it's not a cardiac problem at this point. No pulse felt, JVD may show up. They may have DVTs or had pulmonary embolisms in their past. They may have had recent surgeries or delivered a baby recently. The only thing we can do for them, they need to be lysed. So we give them fibrinolytics in the hospital. You're going to give them heparin. We're going to put them on heparin IV. They may actually need to have a surgical embolectomy done. So we need to recognize what this is. We have a real big fast drop in the SATs when you start having a PE and stuff. You'll see their SATs, and despite your great ventilations, it's not going to change much because it can't exchange the gases between the lungs and the venous system coming in right side of the heart. You get a block going into your pulmonary artery, so you can't get the blood transfused back and forth to be perfused adequately. So there you go. And you'll have some backup, and that's why you'll have your JVD. With your heart, you'll have an acute massive MI, so you're looking for AMI. You'll have 12-lead EKG changes. You may have Q waves, depending if you're having actually MI at this time. We're looking for our ST segment changes and T wave inversions causing ischemia for inversions. ST segment changes, elevation. We'll run our STEMI protocols. So we'll see a history of cardiac. We'll look at our cardiac markers, and that's great if you're in the hospital, but we're going to see all the stuff we see for acute coronary syndrome pre-hospital. Make sure we have a good pulse with CPR, the best thing we can do at that point. They need a cath, and they even need a cath to go right to the cath lab if we do have return of spontaneous circulation. So those are the things we can look for our H's and T's. With the systole, once again, high quality CPR, IV access, good ventilations, and we might start talking about criteria for terminating resuscitation, and we realize that the patient is not responding to anything. and it's been an appropriate amount of time, you have to start really thinking at this point, maybe even with the family, it helps start directing efforts of let them see that everything's been done. There's no response to anything and any measures, so they start coming into a part of acceptance of what's happening with their family member. And your efforts need to start being more directed towards supporting the family at that point. All right. When resuscitation should be initiated, include do not attempt to look at their DNRs. Are we actually going to start anything on this patient? And that needs to be very clear. It needs to be, they need to have some type of marking on their person, and no one can terminate that unless you have documentation that they're their medical power of attorney, and that's what the patient has asked for, not to have any resuscitation measures done. Survival from asystole is extremely poor if that's what you found out. List reversible causes, the same as PEAs, the H's and T's. And then we'll just assign team members and roles and monitor the performance and see what we can get. See if we can get something spurred from what we do. Rhythms and drugs for asystole. You might go into a slow PEA, terminating into a Brady asystolic rhythm, eventually from the PEA. And epinephrine, of course, is our drug of choice. When we start thinking about these patients without pulses, and we start thinking about termination of these resuscitation efforts, of course, follow your own local protocols. But you should consider the patient fails to respond to your BLS and ACLS, and all your interventions, you start thinking about that with the time factor. So decision to terminate rests on the physician or online medical control based on consideration of the factors that may include the time that actually the person collapsed from the time that people started CPR. So the time that guy was downtime before he had CPR established, the time from collapse of the first defibrillation attempt if it was a shockable rhythm, what other diseases this patient has in his history that predicate him to going into asystole and PEA or a pulseless rhythm. What kind of condition was he? What maybe premedicated, pre-arrest state that he was in before everything occurred? What was his initial arrest rhythm? Was it just, did he go right into a slow Brady in the systole, or did he go right to VFib? Was it a shockable rhythm? And was there any response to any of the resuscitative measures? And how long has it been since anything has responded? You start putting all this stuff together, and I know you have termination. A lot of protocols now do have termination based on some of these factors. It's time, and most of it is time and response to treatment. And comorbidities, it all starts adding up that we're not going to probably be able to resuscitate this patient. If you have any doubts, what you need to do is contact your med control and involve them, and that's where you need to go if you have any problems with your decisions in that case. So ethically, when you start thinking about all those causes we just looked at, not any of the factors by themselves or clearly predict any outcome. So you don't really know. I mean, all you can do is keep trying and get to the point where you realize that there is no response to any of your treatment. So the chances of survival without any response to any of your treatments, the research just shows the longer that goes on without response, the survival rates just increasingly drop along with that time level with no response. You can stop that resuscitation when you determine a high degree of certainty that that patient will not respond to any further ACLS interventions. So you start getting down to throwing bicarbonate and mag sulfate and some of those down the line things that you're trying to rule out almost, and there's no response to that. Well, and you're probably starting to get to the point with the time factor involved and how everything has gone along the way that we're probably not going to be able to respond. This patient's not going to respond to any further attempts. So once again, you can leave that to your protocols or your medical control. So that pretty much explains both the asystole and PEA. So this gives us our cardiac arrest dysrhythmia. So this either goes to a shockable rhythm down this tree and remains there, or it goes to a non-shockable pulseless rhythm, which is the right side of your algorithm. So You need to have a real good grip on that. Our major drugs for that, of course, are going to be epinephrine. And on the shockable side, we do have dysrhythmia, so we need to have antiarrhythmics involved in that also. So you look at probably going to go to your amiodarone. Okay. With acute coronary syndrome, well, we've gone through some of this, but we will cover that again in ACLS. So identification, assessment of ischemic chest discomfort, initial treatment of possible acute coronary syndrome, and emphasis on reperfusion early of a patient with ACS and STEMI protocols and STEMI and showing STEMI. Early identification, risk stratification with ACS, apply the ACS algorithm for initial drugs, dose. So we use that algorithm once again to take care of this patient. And that's what our guidelines are based upon. And the use of reperfusion therapy and clot fibrinolysis. You got to understand and prepare to initiate immediate attempts to defibrillate as quickly as possible. There you go. So drugs or electrical therapy as needed for symptomatic bradycardia, arrest, or sudden death due to mostly ventricular fibrillation, where a lot of sudden death is due to that. Recognize the ST segment elevation consistent with AMI. And on Wednesday, you're going to get a lot more of that with Pat when you start going through your 12-lead EKGs. And we're going to look for those ST elevations and continuous leads. So you'll get a real good grip. You've got a little bit of a grip of it now, and she's going to really fine-tune you way past what we've known at this point. Here's what we're going to use for acute coronary syndrome. We've already talked about going through this with basically a cardiac patients. Oxygen, aspirin, nitro, morphine. We want to get heparin and fibrinolytic, Lovenox, heparin, whatever we may be using. A lot of times we use Lovenox now, just give them that. And of course, fibrinolytic therapy. Recognize symptoms, activate EMS notification to the emergency department. We all want to get this, keep moving and get them right into the cath lab if we need CPR, early CPR and defibrillation. And coordinate them along with EMS system, the ED and cardiology. So once again, it's just showing you that we're just the beginning of the chain. We want to move them right on through with recognition, call a STEMI protocol or a non-STEMI MI, get them in for cath as quickly as possible, and open their coronary perfusion up with stents and other invasive procedures at the appropriate cardiac treatment center. Here's our algorithm for acute coronary syndrome. Okay, so our acute rhythms for coronary syndrome. You can see if we start beginning, we got symptoms suggestive of ischemia or infarction. That's what we're getting called for. So EMS assessment and care in the hospital preparation. So monitor ABCs. Be prepared for the person to be going into a pulseless rhythm and quick defibrillation. That's why you're going to have your fast patches all ready to go. We can start giving them aspirin, give them oxygen, nitro, morphine as needed for pain and comfort. Get a 12-lead with ST elevation. Notify the interpretation. Time of onset and first medical contacts. We start working ourselves, got the clock working there as quickly as possible to see where we're really at with time. Notify the hospital and call STEMI protocol. Hey, we got a STEMI coming in, okay? And consider pre-hospital. So we are allowed in EMS in this state to give a clot buster pre-hospital using a checklist, making sure that we're not giving. But most protocols that you'll be seeing here still don't really have pre-hospital thrombolytics being given. Except unless you call the stroke unit, but that's for another cause. So once we get in the emergency department, in less than 10 minutes, they're going to go through their checks, IVs. We'll hopefully have all of this stuff done. What would be great if we can just have the IV done, have the evaluation, have oxygen, have a brief targeted history and physical exam. They already know that. Have this checklist already done. Check for counterindications. Then the ER will be looking at our cardiac markers, our troponins and myoglobins and so forth. Electrolytes and coag studies to see what's going on, to make sure we can give them a fibrinolytic if possible. We want to get a chest x-ray to make sure what's going on in there. And they're going to continue basically that same treatment that we're doing here in the pre-hospital setting. We interpret the EKG, which we've already done once, and they're going to confirm that here. But we start seeing that we go to the left side, we have ST elevation or new or presumed new left bundle branch block, which is a significant change. That strongly suggests injury for STEMI protocol. We have already established this. They are reconfirming that with their markers and other diagnostics. So now we're going to start some adjunctive therapies as indicated. Don't delay reperfusions. For the time of onset is less than or equal to 12 hours. Then we're looking for our elevation of our cardiac of our markers. Once again, refractory to chest discomfort. Taking his nitro and it just isn't working. This or that. If it's less than that, we look for reperfusion. Door to balloon inflation times at least 90 minutes. So that's why we have to get times. When did this start up here? All right. When did we figure out when this stuff was all starting to happen? Once we establish and get that all figured out, we can figure out what our timeline is and what we've done so far. And like I said, if we can get them in to the cath lab in less than 90 minutes, we got a lot better outcomes. Door to needle, if we're going to just go ahead and we just go ahead and try to open them up with some fibrinolysis, clot, anti-clot therapies, TPA, whatever you're using, then we can use that also depending on where our location's at. If we have ST depression or T-wave inversion, that's also very strong suspicion for ischemia. So it's still high risk, but it's a non-ST elevation. So it's not a ST elevation MI, but still very strong high risk. Non-ST elevation acute coronary syndrome. And then we start looking at our markers and start doing our therapies. And then once we see our EKG fibrillation, we may have a normal or just a non-diagnostic type changes in the ST segment or T wave. That brings us down into more of a lower intermediate risk. So then we consider admission. They got more time to work at them in the hospital. They may get them an appropriate bed, keep them comfortable, and then those guys might go for a cath the next day or two. All right, so they'll just keep an eye on them to make sure that doesn't change, but they will be admitted. But they're a lot less risk for anything going on that's dangerous at this time. But that's why they have to stay in the hospital in case that changes. And then we move over to one of these. Okay? With bradycardia cases. So we're going to look at anything heart rate under 60 to 50 a minute, depends. All right. Mostly we consider under 60 as bradycardic. We want to differentiate between signs and symptoms that are caused by slow rate versus those that are unrelated to that rhythm. Some people have a normal resting heart rate of in the 40s. Are we going to treat those guys? No. We get called for something else, and then we see this guy's got a heart rate of 45 or 50, and it's like, wow, this guy's bradycardic. We need to bring him higher up. It may not be related. We want to diagnose a person if there's any type of AV blocks, because these seem to be bradycardic also because of the rhythms that pick up an AV block and they're in the junctional or ventricular rhythms that may pick up below it to pick up the pace. Atropine is a drug of choice, so we can go ahead and start use of atropine in any one of these bradycardic cases. Some of the atropine will be less and less effective as the block is lower and lower down the electrical tree of the AV area. When are we going to use, get to the point where we use transcutaneous pacing? When to start using epinephrine or dopamine to maintain, so we start getting some pressure results that we want to increase heart rate and pressure. And call, of course, consultation. That's what we're going to call our med control for. So signs and symptoms, the causes of the bradycardia, determine whether signs and symptoms are bradycardic or hey, maybe I'm having PVCs by Gemini, so that's why my perfusing rate is only 40 because I'm having every other beat is going to be a premature ventricular contraction. It's not perfusing. You're not counting those in your rhythm. So I have 8 complexes, and every other one is a ventricular complex. I need to treat that bradycardia, and hopefully that'll make those PVCs go away. So identify second and third degree AV blocks. Describe the indications for transcutaneous pacing. And look at the doses that we use during bradycardia. So with atropine, epi, and maybe dopamine if we get to that point. Consider sedation for transcutaneous pacing if we have enough pressure. So we have sinus bradycardia. These are bradycardic rhythms. First degree heart block, AV block. Second degree AV block type 1 or Mobitz 1 or Winky-Bach, 1 Winky-Bach. Type 2, Mobitz 2 Classic, like your second 2-to-1, 3-to-1 blocks. And then, of course, your third degree AV block, which will hopefully pick up with a junctional escape rhythm, depends how high in the AV section that it's occurring from. Or you may have a ventricular escape complex. That'll be your perfusing rhythm, which is, both of them are very bradycardic. More bradycardic from junctional to ventricular. So here's an example of first degree heart block, just prolonged, of the PR interval is prolonged. Usually rate here for this guy is 50 to 60 already, so it's not really that bad, probably not too symptomatic. Probably don't treat these guys half the time. The next one down, we see a Mobitz second degree block, Mobitz 1 or Winky-Bach. So you can see the gradual progression of PR interval lengthening. We've gone through this already. You guys should be able to recognize this. There's regular, longer, dropped. So you can see that progression to help you describe that is a type 2 Mobitz 1 or Winky-Bach. Here's a second degree block, Mobitz 2. All right, so your Mobitz 2, you see you have 2 P waves. We have 3-to-1 conduction, 3-to-1 conduction. So we have 3 P waves, and we are only conducting one complex. And then we have third complete heart block, third degree AV block, where there is no association whatsoever with these P waves and these ventricular complexes. You can see these. This is probably because of the rate and my 5 criteria for ventricular rhythms. It's the right rate, it's regular, it's wide and bizarre, there is no P waves, and the rate of between 20 and 40 is telling me that's a ventricular escape rhythm. And basically then I'm looking at my rate for my P waves are all unrelated. This one's buried in here. You can see a little change in here. And that coincides with this. So there's a beat here. There's no P waves associated with that. This one might look, hey, what about this? Well, that looks like it, but these aren't, and these P waves are firing all at the regular rates, all on their own, in their own rate, and they're not really associated with this ventricular escape rhythm whatsoever. So adult bradycardia with a pulse. Here's your algorithm. Assess the heart rate. Typically, less than 50 becomes more of a bradyarrhythmia as far as being symptomatic. Is it symptomatic or is it unstable? Look for the underlying causes. Take a 12 lead. Look at all that. Maybe he's having an MI, and inferior MI is frequently associated with bradycardia. Maybe we treat that. Maybe we need to be treating that. If we have a persistent bradycardia, so we start looking at some other causes for bradycardia. Is it hypotension? Does he have altered mental status, signs of shock, and so forth? Does he have any type of ischemic problems or acute heart failure from that? If it's no, then we just continue to monitor and observe him because he's not having any of those persistent type of symptomatic and maybe possibly unstable type of symptoms that are unstable at this point. If he does have that persistent problems and those different types of signs and symptoms, and he's becoming more unstable and more symptomatic and continues to have those, then we can start thinking the use of atropine. If it's ineffective, we could start thinking about transcutaneous pacing, or we could start thinking about using some dopamine for pressure, and that also will give you a little increase in your heart rate, or an epi infusion, which will give you also a pressure and chronotropic effect to make you speed up. You can see to the right the doses for the infusions. You look in your protocol, you'll see how to mix. The dopamine is usually mixed, pre-mixed, where you have usually a concentration of 1,600 micrograms per milliliter. Usually it's 800 micrograms in a 800 milligrams in a 500 bag, or 400 milligrams in a 250 bag will give you that concentration. And use your charting, or you can figure it out the long way if you'd like. The epinephrine drip, you'll mix it in your protocol books. You take a look at that. It's a real easy mix. It makes it easy to calculate your 2 to 10 mics per minute. Okay, to titrate your. and then titrate to response. That means to his increase in heart rate and perfusion. Once we get down to those things, we start thinking about considering other expert consultation. And if you haven't paced anybody by this time and they're still persisting with these symptoms despite your treatment here, I mean, we can consider it way here, or we can consider doing that. So it's not bad. So this is giving you the decision to go with this or go here first or go here first. Once you get this far, you don't have anything. If I haven't paced him at this point, I need to start thinking about getting that done. Okay. Unstable tachycardia. So now we talked about our slow rhythms. Now let's talk about our fast rhythms with pulses, how to treat them. Classify them and give them appropriate treatment and other factors and synchronize cardioversion. So is it stable or unstable tachycardia? What's the priority of tachycardia rhythm that he's in at that point? Unstable patients follow the arm of the tachycardia. So we go one side stable and one side is unstable. Look at the energy levels for the different cardioversions for tachycardias. Demonstrate some safe procedures. So make sure you know how to use your machine and how to cardiovert somebody safely so you don't hurt yourself. So unstable tachycardias can either be atrial fib and atrial flutter with rapid ventricular responses, supraventricular tach like a PSVT, a re-entry, so it just stays in one spot and just goes round and round and round. You do get some perfusion with that, but the rates are very high and it affects your filling and your perfusion. If we have monomorphic VTAC with a pulse, these are all with a pulse. Are they stable or unstable? Polymorphic VTAC, that makes me a little more nervous. Is that what it is? Or is it just a wide complex tachycardia? You're not really certain, like it may have a bundle branch block or some other aberrancy in the QRS, but it really isn't originated from the VTAC, but it's so fast it looks like VTAC. So you might be upper supraventricular, but it's hard to discriminate. You know, you're not sure because the guy's awake and got a pulse with it. So, unstable tachycardia, the heart rate's too fast for the patient's clinical condition. Excessive heart rate will cause symptoms that make them unstable because it's too fast. Your cardiac output's reduced. Your beats are ineffective, so that the coordination between the atrium and the ventricles themselves reduce your cardiac output. You're not getting low. You're not loading anything. You're not stretching the heart. You're not allowing for enough adequate perfusion because that rate's making you symptomatic to unstable. So your signs and symptoms of unstable tach are hypotension. You start have altered mental status. Other signs and symptoms of shock as you typically think of it. Might start having some chest pain. Might start having heart failure because things aren't your pump's not working effectively. So what's going to happen? You're going to have heart failure. At rates at over 150, usually do not cause significant signs and symptoms. In ventricular rates of over 150 or less than 150. I'm sorry. So that's why that's kind of the cutoff. So 150, we can still tolerate that pretty well and compensate. But once we start going faster than that for any of those other rhythms, that the ventricular rate is now going over 150, that's where we start having some problems with signs and symptoms and stability. So 2 keys to manage it. Rapid recognition of symptomatic or unstable. If they are symptomatic, or at least they're going to be symptomatic, or why would they be calling us in the first place? And then recognize the signs and symptoms that are caused by the tachycardia, which we just talked about those. So look at the hemodynamic stability or instability of that patient. So it's stable or unstable for everyone, all right? And that's where your treatment takes place. Rates will be over 150 with narrow-complex tachycardias. We want to cardiovert these people with a regular. So we have a regular R to R. So there's your regular part. Narrow-complex, like an SVT, or PSVT, or whatever you want to call them, all right? But it's regular. The R to R is regular. We can start them as low as 50 to 100, all right? With a narrow irregular complex, like so AFib or a flutter, with varying flutter waves and a rapid ventricular rate over 150 and symptomatic or unstable. We start them anywhere from 120 up to 200. If any of these don't work, like the lower ones don't work, you do increase them up to try to get conversion. With wide complex regular tachycardia, we can start them right at 100. Wide irregular complexes, defibrillate, do not synchronize. Why do regular pulse complexes without a pulse? Without a pulse, you defibrillate. So you can look at some of these different causes here. So if you do look, here's 100, here's 100, 120. So if you're starting at ranges, no matter if you're early, a little bit uncertain about this because the rate's so fast, you can't tell if it's regular or irregular. You start at these higher ranges and mid ranges here, you're going to probably be pretty good shape. All right. With a wide regular complex, if you're unknown origin, if you think it's V, even if it's VTAC with a pulse, you can still start here. Or if it's just a wide complex of unknown origin, you can go ahead and start with that also. Or a dose of adenosine will be okay also. So here's your adult tachycardia with a pulse algorithm. So we want to assess the heart rate, typically over 150, right? That makes it tachycardic. Very tachyarrhythmic. Maintain your basic IV O2 monitoring. Okay, same kind of stuff. Watch your pressures and watch your patient if he is causing, now starting to have hypotension, altered. So all these are unstable signs here. Once this patient becomes unstable and he's yes, we want to go ahead and cardiovert these people. So consideration, but we have to keep an eye on our blood pressures. If it's regular narrow complex, we can consider giving them adenosine first. We could also consider maybe giving them vagal maneuvers. But we can go to adenosine if they're stable. If they're not stable and they're really going into this portion of it, then we can go to synchronized. Once it's unstable, we probably want to start thinking about cardioverting them. Here's narrow regular, start 50 to 100. If it's irregular and narrow, we go from 120 to 200. Right. If it's a wide QRS, yes, I can give IVX. I can consider adenosine if it's monomorphic only. So if I have a wide monomorphic Tach that's becoming unstable with a pulse, I can consider the adenosine as appropriate treatment. Other than that, I can start thinking about antiarrhythmic infusion, which we'll see next, which would be procainamide, stable wide QRS. Or we can give them amiodarone, 150 over 10 minutes. All right? We can give them propanamide, 20 to 50 milligrams per minute. And we just got to watch for widening QRSs of greater than 50%. And we start giving some of these medications, and then it gets too wide, then we're hurting them, and we're not perfusing with that either. Or we can cardiovert them also, if we have to. Wide regular at 100, we can start there. IV access. So if the wide QR is widening, we can do with vagal maneuvers. So we can also go when the guys are not stable but symptomatic. If these are unstable, that go to yes to cardioversion. Wider than that, yes, we go to this stuff here, and we consider cardioversion at the point too also. But if it stays not only symptomatic versus unstable, we can go right down to vagal maneuver, adenosine, if it's regular, beta blockers or calcium channel blockers. At that point, we're just trying to slow down the rate to make them less symptomatic if they don't convert from adenosine or vagal maneuvers. Get a 12 lead, help kind of clue things in. We have a change in rhythm after any of these measures, we get a 12 lead because we have a change in rhythm and reassess it. For stable tachycardias, it either be wide or narrow, or regular or versus irregular. Be prepared for Bradycardia. Once it becomes unstable, we go right to cardioversion if we have to. So we do the same thing. Differentiate between tachycardia narrow and wide. Treat them down the algorithm as stable. For narrow complex QRS, SVTs, tachycardias, so all these could be included in narrow complex. Sinus tach. Well, it won't be sinus tachycardia. It would be SVT because the rate's going to be over 150. Atrial fibrillar rapid ventricular response, atrial flutter with a rapid ventricular response, or like a PSVT that will just re-enter at the same spot, and that would make that regular also. All right. This would be regular. This may be regular or irregular. This will be irregular, but narrow complex. The wide complex tachycardias go from monomorphic to polymorphic VTACs. or irregular tachycardia, so a wide complex tachycardia that may come from an aberrancy or a bundle branch block. Irregular narrow complex tachycardias are more likely, like I told you before, would be probably AFib, because AFib is irregular. A flutter is it can be regular or irregular, but most of the time it usually is fairly regular. So narrow complex tachycardia, we can go right down for stable tachycardia. So narrow complex tachycardia, we can do vagal, adenosine, go to beta blockers and calcium channel blockers. Once again, this is a conversion agent. These are for rate controls. With wide complex tachycardias, that are stable, we can go with amiodarone, like we said before, procainamide, Satilol, that's another beta blocker. We could give them a trial of adenosine if it's uncertain of the origin, like an aberrantly conducted wide complex tachycardia, but still originating above the AV node, but we can't really tell. We could give them a trial of that, especially if it's monomorphic. So we went down the tree before. Unstable, yes, we go right to here. Unstable, no matter what those are, and those are the different energy levels for narrow regular, narrow irregular, wide regular, and wide irregular. All right. And if it's stable, which is what we've been talking about, no matter what, if it's stable, then we can go right down to this block, straight down the tree. This is the stable block. This is the unstable side, so the right side is becoming more unstable. Okay. The next thing I want to talk about is acute stroke cases. So this case covers the principles of out-of-hospital care and fundamental aspects of initial and in-hospital stroke care. So we've talked about stroke when Dan came in and talked a lot about it with the stroke unit and its capabilities. That gives us a whole other option in this area to think about calling someone, depending where you're at, to get them a more quick, focused treatment and diagnostics done right in the field. Most places don't have the availability of that, but we do in this area. So our focus out of hospital is rapid identification, assessment, and rapid transport to a stroke center, or in our case, we can call a stroke unit right to the scene and start the stuff the stroke center would do right at the house. Hospital then, at that point, determine they'll call stroke alert, just like they call a STEMI alert now. Then they will give them, if it's not started in the field with a stroke unit, they will look at fibrinolytic agents, and then we'll probably go right to the intervention center if they're a candidate for intervention. And there's a clot in the way. The clot causes most of the problems, 60 or 70% of the time. Signs and symptoms. Cincinnati Stroke Scale, you guys have learned some other things on the race scale, so you'll even have a more in-depth assessment of it. Let's just go over the Cincinnati scale. The 8 Ds of stroke care, general care issues that we'll deal with pre-hospital. The potential for arrhythmias with stroke are more specific for stroke than others, but if you have a long history of a recent MI or long-standing atrial fibrillation, that's going to predicate you to stroke. So the association with a recent MI or atrial fibrillation, like my father's being treated for atrial fibrillation since he's been 40, so 40 years now, and probably 5 years ago he did have a stroke, a minor stroke, but it's a great place to the atriums are a great place to grow a clot when they're not firing and squeezing the way they're supposed to. So always want to monitor. Any stroke patient is going to be on a monitor. So we'll look for TPA. Use of that, D50 if it's something wrong with that. Labetabol, so that's just a beta blocker. We'll use it to help control pressures, but the new thing is to use the nicardipine. That's a calcium channel blocker. That'll be used to help with blood pressure control. We don't want to drop the blood pressure too much because that'll be detrimental. And also start looking at some other things like aspirin and nitroprusside for treatment of stroke. So the 8 Ds of stroke care for us. We want to detect it. We want to get it dispatched. We want to deliver it to the door as quickly as possible. We want to date it and we'll decide right off the bat. We can probably call a stroke protocol, or if we do have the availability of a stroke unit, that they will come and they will start the stroke protocol right then and there that we'll be doing in the hospital. What drugs will be used in the disposition of that patient. He needs to go to a stroke unit, or it's something else like low glucose. That's why glucose is and dextrose is on there, because maybe it mimics so much that it has to be ruled out by us immediately that it's just not a drop in blood sugar. So with the National Institute of Neurological Disorders and Stroke, here's some criteria for time goals. That's what they're basing all these on. So general assessment for the stroke team, ER physicians, and other experts within 10 minutes of arrival. We are starting to do that in the field. We are getting more and more of that. So that's why our race scores are more advanced than what this was set up to be. You want to get urgent non-contrast CTs. We can do that in the field now. So you can see how quickly that's going to, before we even get to the hospital, that can be done. We can actually, if it's a TPA patient, they also start the administration that before they even get to the hospital. So you can see how much time they're going to cut 10 or 15 minutes off the hospital. Huge when you're considering that the stroke might be proliferating. The longer we leave it go, the more damage is being created. Interpret CT scan within 45 minutes of arrival. So you can see the impact of the mobile stroke unit if you have availability of that, to get that done before we even get to the hospital and the ER. And the initiation of the fibrinolytic therapy, we can initiate that also with the CT clearance. So our door to admission time was cut dramatically at that point. Here's our management for stroke for 2015. So you can see how the algorithm, and they're just giving you the times to from ED arrival for 10 minutes. We want this all done. In 25 minutes, we want the neurological assessment done. In this NIH stroke scale, CT shows hemorrhage, no hemorrhage versus hemorrhage. 45 minutes. They want this done. So you can see if this is done immediately, it dramatically cuts this time down. If it's non-hemorrhagic and we can start thinking about giving them TPA, we can actually do that in the field now. Patient remains a candidate. Candidate review, so the TPA is given. So you can see the stroke admission all within 3 hours, and ED arrival and some of this intervention hopefully within 60 to 90 minutes. If there is hemorrhage, then what we want to do is then we have to consider is not a candidate. We might be able to give them some aspirin, but begin stroke hemorrhage pathway, which is not here, and then that's going to be done by the neurologist on duty. All right, so, and we do have a stroke center. We have a couple of them up here, so that's an appropriate place for you to be going. So, this is just going to go over Cincinnati pre-hospital stroke scale a bit. So, facial droop, have the patient show his teeth. So we have a normal, both sides is equal, or abnormal, one side does not move as well as the other. The arm drift, you make them close their eyes and extend both their arms out with the palms up. Hold it for 10 seconds. If they're having difficulties, you see one arm will drift down compared to the other. They can't do anything about it. And we test for abnormal speech. So I have the patient say, you can't teach an old dog new tricks. I'm sure glad I got through that without screwing it up. So normal finding is he can use the correct words with no slurring. Abnormal is we got slurred words, wrong words, unable to speak at all, some type of dysphagia like that. If any one of those three signs is abnormal, so the probability of stroke is up to 72% if only one out of those three is up. All three are there, 85% or more, so that pretty much shows you that. So here's kind of how it looks. Here's your facial droop, what you're looking for, normal and abnormal, arm drift, normal and abnormal, and of course the speech. And once again, the probabilities of that. So you can see this, just doing this simple a Cincinnati scale, how predictive it is for stroke, that we want to go ahead and move on them as quickly as possible. Here's some general management of the acute stroke patient. IV, avoid using the D5 because if it is a bleeding problem, it's very rough on the cerebral tissue for one thing. We want to correct hypovolemia. If we do have some of that, it's causing some of our problem with perfusion. Maybe that's just a perfusion problem. So we're going to want to use saline anyway, so it's easier. Blood sugar. Determine immediately if he's hypoglycemic or not, because maybe this is what's giving us our symptoms. So you sure don't want to drive in to the hospital, have a stroke protocol called, and you didn't stick the guy's finger and see his blood sugar was only 32. So we always rule that out right off the bat. Use your knowledge and what you've got to cause any kind of altered mentation of any kind. You can always just do a quick blood sugar test and rule that out completely. Put them on a cardiac monitor, oxygenate them to at least over 94%. If they're febrile, we can give them a little acetaminophen if you have that availability. Basically, we want them NPO as much as possible. So we'll keep that intact. They might not be able to swallow, so all that goes along with your stroke scale, the stuff you're assessing for, that Cincinnati scale. If they have trouble with speech and moving their face and stuff like that, it's going to affect some of the glossal and hypoglossal nerves that have to do with swallowing. We sure don't want to make them swallow anything if they can't. That pretty much takes care of our ACLS protocols, what you'll get in the ACLS, the treatments and so forth, and guides. Please use this guide, and I'll try to maybe give you some algorithms, some sheets for that, some trifolds. You can look at your protocols that will pretty much follow that guidelines for ACLS. But these are the ACLS guidelines. This is what you'll have for the fall when you do ACLS. You'll actually take ACLS class. So just be up on this stuff. This will get you through everything we got to do pre-hospital. So it's all pretty good. Pretty good guide for us to use. That's what everything's based on for us for cardiac and stroke. All right. Thanks a lot.